Hi, everybody. Good afternoon, and welcome to Cure PSP's Ask the Expert webinar. Thank you, everyone who's tuning in today via YouTube and Facebook Live. We're really excited to have you all with us. I'm Jessica Shore. I am the Director of Patient and Care Partner Advocacy here at Cure PSP, and it is a privilege to be moderating this program today. To kick off the relaunch of our quarterly webinar series, today we have Dr. Chantal Boisvert, who will be addressing vision changes with progressive supranuclear palsy, corticobasal degeneration, and multiple system atrophy. But a few housekeeping items before we get started. This will be a recorded webinar. Dr. Boisvert has agreed to share a copy of her slides with the registrants. Her slides and the link to the recording will be provided in a follow-up email, so please be on the lookout for further communication. The webinar will also be archived on our website and our YouTube channel for anyone to view later. Dr. Boisvert will likely address many of your questions throughout her presentation, but we will still have time for Q&A at the end. You're welcome to type your questions into the comment section of the platform that you're using. We also have the questions that many of you had submitted when you registered. And of course, you're also welcome to use the comment box to say hi and share with us where you're tuning in from. If we're not able to get to your question today, we encourage you to email us at info@curepsp.org, and we'll do our best to get you an answer or connect you with the right resource from there. Those are my housekeeping items. So at this time, I would like to introduce our speaker for today's Ask the Expert webinar.
Hey, Jessica.
Today we have Dr. Chantal Boisvert. She is an associate professor of ophthalmology and chief of the Neuro-Ophthalmology Division at the Duke University Eye Center. Her clinical interests include all aspects of neuro-ophthalmology, including the diagnosis and treatment of a variety of optic nerve, cranial nerve, and brain disorders affecting vision, and she sees many patients with neurodegenerative disorders. Additionally, in her clinic, Dr. Boisvert performs a variety of surgeries and procedures, including eye muscle surgeries to correct double vision and botulinum toxin or Botox injections for the treatment of blepharospasm and hemifacial spasm. And I want to add that prior to joining the team here at Cure PSP 6 months ago, I worked in the Movement Disorders Center at UNC Chapel Hill. And while there, Dr. Boisvert and I shared many patients over the years, and she was generous enough to, with her time, to present at all 3 of my local support groups. Dr. Boisvert is quite specialized in PSP, CBD, and MSA at this point, and we asked her here to share her wealth of information with you all. So Dr. Boisvert, welcome. It is always a pleasure to get to see you and get to work with you, and please take it away.
Thank you so much, Jessica. It's really a pleasure and really an honor to be here today. So I have a lot of slides today, so I'll try to really focus on the very important things. So we'll be talking mostly about PSP, CBD, and MSA, and how those diseases can affect the vision. So if we start with what is a neurodegenerative disease, I mean, you probably already know about that. So next slide, please. These are pretty rare diseases, but those diseases can affect people in their active years. So they are very, very debilitating diseases. And they are usually characterized by personality changes, behavior changes, language, and motor decline as well. So if we start with PSP, it will affect about like 17,000 people here in the US, but a lot of people are actually misdiagnosed. And those patients will have a loss of balance, changes in personality, eye problem issues that we will review extensively in a few minutes, a slurred speech and difficulty swallowing. So next. So MSA affects a little less patients. It's about 13,000 people, and will also include problem with swallowing and speech, but also often patients will have changes in their blood pressure with movement. So next slide. So CBD is much rarer. It will affect about 2,000 to 3,000 people in the US. And the symptoms are very similar, right? The balance will be affected, speech as well. And patients are often very stiff and clumsy and can also have dementia. So yes, thank you. So we do have other diseases that we'll not be talking about today, but are also part of the same spectrum of diseases. But I will really focus on the three first ones today. So if we start with progressive supranuclear palsy, this is the one that I really want to focus on because that's by far the one that will have the most eye and vision changes. So we'll spend quite a fair amount of time on that disease. So PSP does affect the control center in the brain that affect the eye movements. So that being said, it means that the patients will progressively lose the ability to move the eyes. The visual symptoms don't start right away. It takes a few years after the balance issue starts before the patients will start complaining about the vision. So next slide. So if we look at what is affected in PSP, so we will have abnormal eye movements that we'll talk about in just a few minutes. Patients also have a hard time maintaining eye contact, also have difficulty with the eyelids. So it could be more difficult to blink, or sometimes it could be the opposite. The eyes can stay closed, and that could be either from Blepharospasm or from Apraxia of Lid Opening, and we'll talk about that as well. And dry eyes and blurred vision are also very, very common in patients with PSP. So as I said before, the eye changes do not start right away. It takes a few years before the patient actually starts noticing the problem. Very early on, the movements will be full, but they'll be a little slower than before. So at that point, the patient is not symptomatic. So if we continue and we progress in the disease, so next slide. So then we'll start seeing some changes in the eye movements. So the first movements that will be affected are the vertical movements, so looking up and looking down. That is really what will tell us sometimes, what will give you the clue that the patient might have PSP. So I do see a ton of patients with Parkinson's disease or Parkinsonism that have not yet been diagnosed with PSP. When I do my eye exam, if I look at the eye movements and I see that looking up or down are affected, then PSP becomes much, much, much higher in my differential diagnosis. So in that case, I will contact the neurologist and say, hey, have you noticed the eye movements? Because with my exam, it looks like that patient might have PSP. So the limitation in up gaze is not specific to PSP, but the down gaze limitation is pretty specific for that condition. And of course, looking down is essential. You need to look down when you walk, you eat, you read, when you go down the stairs. So looking downward can, or the absence of looking downward can be very problematic. And we'll look at how we can improve that in a few slides. And as the time goes on, the eye movements will just keep getting worse, and eventually even looking to the right and to the left will be affected. But that's much later in the course of the disease. Next slide. So why is it difficult to read? But as I said before, when we read, we have to look down. And the way the glasses are made, usually the near vision is in the lower part of the vision. So when you have bifocals, when you look straight ahead, you have the prescription for distance vision. If you want to read, you have to look down into your bifocals. And it doesn't matter which type of bifocals you have. So it could be the first one on the top here with the line, or the line that goes across the lens, or even the progressive lenses. It's still like in the lower part here that you have your near vision. So all those glasses, you have to look down. And the progressive lenses are probably the worst, because it's a progression. So if you want to have the full amount of the power that you need for up close, you have to look way down in the glasses. If you compare with the bifocals with the line, it's as long as you're below the line, you have the full vision for up close. So looking down is hard, so bifocals are definitely not ideal, and the progressive lenses are probably the worst. And another issue that we hear over and over is the difficulty finding the lines. When you read and you want to go back to the next line, it's very difficult to follow that with the abnormal eye movements. So next slide. So what can we do to help? So instead of wearing bifocals and have both distance and near in the same glasses, you can go with single vision readers, meaning that they are just reading glasses. So you don't have the line, you don't have a progression. The entire lens is made for up close. It means that if you want to see a distance through the glasses, you won't see. So you'll have to look over your glasses. But at least when you want to read, you won't have to bring the eyes down or move the eyes down to obtain clear vision. So by doing so, so if we want to go back just a second, I just want to talk about it's really easier to bring the book up. So you bring it at eye level, and since you don't have to look down with the single vision glasses, it's much easier to read that way. And sometimes even doing that is not working, and then we can start thinking about doing audio books instead. Okay, now we can go to the next slide. Another problem we see with PSP, and this is not specific to PSP, we'll come back to that with the other conditions as well, but it's what we call convergence insufficiency or paralysis. So the convergence is when you bring your eyes inward. So we have to do that when we read. And with PSP, we can no longer that. So instead of going inward, the eyes will stay straight. So patients will have double vision when reading. So the way of fixing that is either by covering one eye, so that way you only use one eye and the double vision goes away. You can also try prism glasses. Some exercises sometimes can be attempted, but it's really rare that it's actually working with PSP. So if we go to the next slide. So the prism glasses are just like you can see here on the one side, there's a line over the glasses. So those lines are the little prisms, and that will bring the second image on top of the first one. So it does work if it's not too severe. When it becomes more severe, the amount of prism that you need is too high, and it's not possible to put that in glasses anymore. So that's when patching becomes the best scenario. So if we go to the next slide, so patching, we have different ways of doing that. So you can wear a parrot patch or buy adhesive patches, the same ones that we use in kids for treatment of a lazy eye, for example. Or we can also put a Scotch tape over a lens, or there's a special foil that we can put on one lens. So it doesn't really matter what you use. The goal is just to close one eye, so that way you're using only one eye. So looking down, you need that for eating as well. So it might be more difficult to visualize the plate and see where the food is at. So another way of improving that is by putting the food a little further away from the patient. So that way the patient doesn't have to look all the way down to see the plate. So going downstairs is another problem. So the patients have to learn how to bring the chin down instead of bringing the eyes down. So by bringing the chin down, the eyes stay more in the middle of the socket, so you don't have to look down as much. But of course, if it's hard looking down in the stairs, there's a higher risk of falls. So we have to be very careful about that. So I don't know if we can start the video. I don't know if it's going to work. Do you see a little like arrow on the video? I don't know if it might not start, right? That's okay. So another abnormal eye movement that we see with PSP is what we call the square wave jerk. And the video was just a video of that, but I can show you what it looks like. So instead of fixating on the target, the patient will just move their eyes back and forth nonstop. It's like a constant movement. And that will interfere with fixation and with reading as well. So next slide. So another eye problem that we see is the inability to maintain eye contact. So the patient will always start looking away from you. So it will give a false impression that the patient is not interested. So just be aware this is also part of the condition. So we talked about the abnormal eye movement. So we can also have abnormal eyelid movement, and it could be either too much or too little. And we'll review all of the different things that can happen in a second here. So next slide. So if it's too little, it means that the patient is not blinking. A normal person should blink about 15 to 25 times per minute. So the lids are really the wipers of your eyes. You need the lid to bring the tears down and remove all the debris that are accumulating inside your eye. With PSP, the average is about 3 to 4 times per minute. Because you're not blinking, you don't have the wiper effect, so that can lead to dry eye. Next slide. Now, if we talk about too much, patients can also have blepharospasm. So that's really the opposite. Now the eyes are closed and they cannot reopen. And usually blepharospasm is very forceful. You try to open the eye and they don't want to open. Those muscles are super strong and the patients will just keep the eyes closed. The patient is not blind. The patient can see when the lids are open, but because the lids just stay closed, the patient can become functionally blind because the eyes are covered by the lid. And one important thing with blepharospasm is it goes away when the patient is sleeping. So there are other conditions that can give like a forceful closure of the eye, but the other one doesn't disappear with sleep. So this one does disappear. So how do we treat that? Well, blepharospasm can be secondary to PSP or can also be secondary to dry eyes. If your eyes are dry, you'll have a reflex to close your eye and you might want to keep your eyes closed. So if you do have dry eyes, you want to fix that as a first step. Medication is not that great for blepharospasm. We can try muscle relaxants or even sedatives, but that doesn't work that well. We can try the eyelid crutch. The crutch, I don't know if you can see here on the glasses, there's like a little part here that goes above the eye and will push on the eyelid to keep it open. Doesn't work that great for blepharospasm because of the forceful closure. So even if you put that bar there, it's not strong enough to keep the eyes open. So really the first line is botulinum toxin or Botox. And we'll go to the next slide. There are different ways of doing that, but I'll say that in general, you want to do some injections around the eyes and around near the eyebrows where the muscles that take care of closing the eyes are located. Another similar problem, which is kind of a milder version of blepharospasm, is the apraxia of lid opening. The patient can open the eye, but for some reasons, once in a while, the eyes won't open. It's not forceful. You can see here that there's no active contraction of the muscle. It's very soft. But for the patient to open the eye, the patient has to actually lift the lid with his fingers. The crutches can work for that condition here because it's not forceful. You can also try to tape the lid up, or you can also try Botox. So if we talk about Botox, it's a slightly different. So the location where we do it differs just a little bit. So we do it a little closer to the eyelashes, and that also works very well. So we talked about dry eyes. So because the patient doesn't blink as much, the patient will have dry eye. It's not a direct consequence of PSP. PSP doesn't give dry eye per se. It's just the fact that when you get older, you have a prevalence of dry eye to start with. If you blink less, then you'll have more dry eyes. So dry eyes will give you a lot of different symptoms. So the reason for that is the tears is the first layer in front of the eye. And you need that layer to protect your cornea and also to give you a clear window. If the tears evaporate, your window becomes cloudy and then your vision also becomes cloudy. And because the light will hit some dry spots on the cornea, then you can start having double vision in one eye. So even if you close one eye, the double vision will still be there just because it's dry and the light goes in different direction. Patients with dry eyes are very symptomatic. The eyes can be very red and irritated, might be even tearing more than usual because it's a reflex. If the cornea is dry, the cornea will tell the lacrimal gland, hey, I need water. And then the gland will produce a lot of tears, but those tears are not good. So you really have to supplement with artificial tears. And when we read or watch television or look at the computer or when we drive, we tend to not blink as much. Even a normal person doesn't blink as much. So all those symptoms will be worse in those conditions here. So we talked about artificial tears. We have different formulations. I will highly recommend the ones without preservatives, just because you can use them more often. Preservatives can be irritating to the eye, and when you have dry eyes, your eyes are already irritated to start with. So you want something that is very soothing and soft to the eye. So you can use them 6-8 times a day, or even more if you use something without preservatives. You can also use a gel, which is a little thicker than a regular tear formulation, or ointment at bedtime. Warm compresses can also help with the glands around the eyes that are producing the fat that goes in the tears and might stabilize the tear film a little bit better. So warm compresses is definitely a good option for patients with dry eyes. If these treatments are not enough, we can also put a little plug in the tear ducts. So that way the evacuation of the tears is slowed down, so the tears stay longer inside the eyes. So it's important to remember that PSP does not lead to blindness. The vision per se is not affected, but the patient can be functionally blind because of the blepharospasm. If the eyes are always closed, the patient cannot see anything. So it's very important to talk about these symptoms to your eye care provider and your neurologist. And if your eye care provider is not familiar with PSP, then a neuro-ophthalmologist should probably be around to help you. So if we go to MSA, so we spend a lot of time on PSP, so MSA, so before we talk about the symptoms, it's important to know that we have different subtypes, and the subtype will tell you what the main problems will be. So you have one subtype that is more related to Parkinson, one that has more autonomic symptoms, like when the blood pressure changes a lot, and some have more the cerebellar problems, which is more like the posterior part of the brain. So there's no real studies or analysis that have looked at eye disease and MSA, but what we do know, though, if we go to the next slide, is that there is probably a link between dry eyes and MSA, especially in the form that is mostly that is related to Parkinson. We know Parkinson has a lot of dry eyes, so that makes sense here. You can also have abnormal eyelid movements, which can be the decreased blink rate, but also can have a blepharospasm, as we discussed earlier. The square wave jerks are also something that can be seen with MSA. So it's just a picture that shows you the eye movements when we trace them. So it's kind of like going back and forth. So it looks like little squares. So that's why we call that square wave jerk. So if you have the MSA-A with the autonomic symptoms, you can have also pupillary abnormalities. So the pupils are controlled by your autonomic system. So if you do have issues with that, your pupils can also be abnormal and might not respond as well when the light turns on or off, or with the stress response. So next slide. So visual hallucinations have also been described in a very small percentage of patients with MSA, but that is strongly predictive of Lewy body pathology, which is slightly different. So it's definitely not something common. We see that with Parkinson's disease, but it can also happen with MSA. So if we talk about the cerebellar form of MSA, affecting mostly the posterior part of the brain, those patients can have double vision and abnormal eye movements. So we can go to the next slide directly here. So the eye movement issues that we see are convergence insufficiency, which is very similar to what we talked about for PSP, but can also be due to skewed aviation. So let's go to the next slide here. So skewed aviation is when one eye is higher than the other, and it's not due to a nerve palsy or muscle problems around the eyes. So it's really coming from the posterior part of the brain. So it makes sense if you have the form that is mostly affecting the posterior part of the brain, then you can have eye misalignment that is from the same part of the brain as well. And we can also see abnormal eye movements. So the vestibular ocular reflex, or the VOR, is when you look at something and you move your head, you're supposed to be maintaining vision on the target. So patients with MSA have a hard time doing that. So the eyes tend to move with the head instead of staying on the target. So when we look at the smooth eye movements, they are a little jerky. So they're not smooth, they're like jumpy a little bit. So we see that with Parkinson's a lot as well. So the saccades are the quick movements. So looking here and there, So they are hypometric, meaning that the patient will undershoot and then will correct it. So it's always undershooting and correction. And downbeat nystagmus. I don't think the video will work here, but downbeat nystagmus means that the eyes are kind of beating downward. And it's worse when the patient is looking down. So reading becomes very, very difficult. So patients with MSA can also have a lot of reading difficulties, especially if downbeat nystagmus is present. So next slide. Oh, it's working. So if you look at the patient here, you can see that the eyes are kind of jumping like downward. So that's a downbeat nystagmus. See that? Boop, boop, boop. So if we talk about CBD, I don't have much to say about CBD. So before we talk about the eye problems, I will say that grossly what CBD is it's a type of Parkinsonism, and patients will have like slowness, muscle stiffness, balance issues, and sometimes tremor, and can also have difficulty performing very complex movements, and also can have dystonia where like they will bring like one member, like let's say like a limb up, and they will stay in that position for like a certain amount of time. Can also have abnormal jerky movement of the muscles, and usually it's quite asymmetric. So one side will be worse than the other. So knowing that, so then we can look at next slide. So we can look at the visual symptoms. So there's not much reported for CBD. So balance and eyes seem to be pretty much preserved. We have to be careful when we look at the data. There's really not a lot of studies that have looked at the vision impairment in CBD. So what we have is actually a very small sample, and usually it's like very few studies with a very small amount of patients. So if we go to the next slide. So CBD also has some subtypes, and I will say that the visual symptoms will depend on the subtype. So if you do have the CBD form that is very similar to PSP, then you can have the same eye movement anomalies that we can see with PSP. If you have the other forms, if you have like the frontal temporal dementia, or like if you go to the next slide, like the one that is mostly presenting with aphasia, usually you don't have that much visual problems from those subtypes of CBD. Next slide. So we don't have a lot of studies, but so far what most of the studies tend to show is that the eye movements tend to be a little delayed. So if the patient is looking at something and wants to look at something else quickly, before the movement starts, you'll see a little lag. So that's the delayed latency. So it takes a little longer to actually start the movement once you want to start moving the eyes. The smooth pursuit, so the smooth movement of the eyes, can also be affected. And there's also some visual spatial problems. So it's really difficult for patients with CBD to localize an object with vision. So there's like processing issues going on. So next slide. So what I can say is that there's no vision loss that has been reported in CBD, and that is actually true for all the different types of Parkinsonisms. Maybe I will say the only exception is probably Parkinson disease. Sometimes patients can have slightly decreased vision, but there's definitely no blindness with those conditions. Light sensitivity is also less common than with PSP, with CBD. So light sensitivity is usually a sign of dry eyes. So if you do not have dry eyes, then it's less likely that you'll have that. Patients with CBD, though, can have lid issues. So apraxia of lid opening. So remember when the lids just stay closed, but it's not forceful. Or the blepharospasm, which is very, very forceful closure of the eyelids. The blink reflex can also be affected, so patients might not blink as often, and patients can also have like the fixation problem with the square wave jerk. Visual hallucinations are very rare in CBD. So that's what I had. It was a very short talk for a very big topic. I'm here to answer any questions you may have. I know I've already received quite a few questions by email. I tried to include them into my talk. But Jessica, if you have any other questions that I haven't answered yet, I'm all yours.
Awesome. I mean, every time I've heard you speak so many times now because you would come to all of my courses back when
We're best buddy now.
But,
We're best buddies now.
Oh yeah, we are. Of course. I mean, where's your half of the friendship bracelet that I'm wearing over there? But every time I hear you talk, I always learn more, and you covered so much. But you know, in thinking about the common questions that we get, and a lot of the ones that have come in the chat and that we got when people registered, I love that we have a lot of time now for Q&A and really to have a discussion. So I would like to start out with asking, do people with PSP, CBD, and MSA always have vision symptoms, and should they expect to have all of these symptoms that you mentioned? I know that, you know, what to expect and what to look out for is a really common concern for folks.
That is actually a very good question. And the only disease that I'll say that is unlikely to not have any vision problems is PSP. Like MSA, CBD, it's very likely that the patients will not have any issues with the eyes. PSP is definitely different. If you don't have the limitation in the vertical gaze, it's either that it's early in the process or you're misdiagnosed. It's part of the diagnosis of PSP. I mean, if you have abnormal vertical movements, that's when we say that it's probably PSP. So those movements are almost always affected. Doesn't mean that it will affect the patient in the daily activities, not necessarily. It really depends on the extent. But if I do my exam, I will definitely see that there is some slowness of the movement and sometimes some limitations. But the patient is not always symptomatic and not always aware of that. Regarding the dry eyes is extremely common in just the normal population. We see patients with dry eyes many times a day, and it's not necessarily that it's related to a neurodegenerative disease. So dry eyes is extremely prevalent in the population. So in PSP, MSA, CBD, it might be just a little higher in terms of prevalence. It doesn't mean that the patients will have that, but if the patients tend to stare and is not blinking as much as usual, then it will definitely increase the likelihood of having dry eyes. Dry eyes is something that is dynamic, right? It will depend on the weather, on what the patient is doing. If there's like a fan that is over like the bed at night or not, if you're in the car with the AC on and the AC is flowing in your eyes, of course, it will make the dry eyes worse. So it's something that is fluctuating. So I will say PSP, usually I do recommend using artificial tears. If I do see some spots of dryness on my exam, then I will definitely push for more. But usually patients will know if the eyes are dry, the eyes will start being irritated, start having a lot of tears and blurriness and burning sensation, foreign body sensation. So if patient starts complaining about that, then I will know that we have to actually go with artificial tears. That's the first step. I always try to tell my patients to not forget to blink. And I know it's hard, but they have to remember to blink. So blinking is super important. So if the blink reflex is not working, then we have to fix the dryness another way. So the tears will help with that, but blinking is by far the best way of improve the dryness. The plugs in the tear ducts is also a very good way, because when you cry, you have a runny nose because your tears will go inside your nose. So if you block that, then the tears will stay inside the eyes, and that will definitely help you. So with PSP, again, double vision tends to be quite common. It's a little later on in the progression of the disease, not necessarily like in the first few years. And usually it starts at near when the patient is reading. And as the disease progresses, it tends to become worse and worse. And that's when we switch to audiobooks, when it's no longer needed. But it's like much, much, much later in the disease. CBD, MSA, definitely not as often. So if I summarize, I will say that the eye movement problems that are noticed by the patients are mostly seen in PSP, and it's really looking downward, like reading, eating, going downstairs, and double vision up close, and the dryness. That's like what I see the most.
Those are the most common.
Yeah. Blepharospasm can happen, and if it is an issue, we can definitely fix that with Botox. It works great. So don't hesitate to talk to your neurologist or your eye doctor regarding Botox. Most doctors are quite familiar with that, and if they're not, they can always send you to a neuro-ophthalmologist, or even like an oculoplastic surgeon, like a lid surgeon can also do those injections.
And I was actually just going to ask about that of, a lot of times with these diagnoses, it can get confusing having so many different cooks in the kitchen as providers and knowing who to talk to about what symptoms. So do you have any thoughts around who is best to manage like Botox for blepharospasm or for eyelid apraxia? Should it be a neuro-ophthalmologist, a neurologist, or does it not matter so much, more just who?
It doesn't really matter. So if I look here at Duke, I mean, I know this facility because that's where I work. So it's probably half and half. I'll say I probably do half of the Botox injections, and the movement disorder neurologist probably does half of the other ones. They are very familiar with that, so they can definitely proceed with the Botox injections. Some regular neurologists sometimes are not comfortable doing the injections around the eyes, and then they tend to refer to ophthalmology, which is fine. But if the neurologist is comfortable doing that, it's totally fine. They know the technique. It's not difficult to do, so it could be either one.
Okay, great. And I guess along those lines of providers, we had a couple of questions around seeing an ophthalmologist versus a neuro-ophthalmologist versus an optometrist. And then there are also sometimes neuro-optometrists. And,
Right.
and I think it especially gets confusing when people have vision comorbidities that, not related to their neurological diagnosis. So I'd love if you could speak to, the difference between them and who someone should see for what.
That is actually a very good question. So I trained as an optometrist first, and then I went back to school to become an MD, an ophthalmologist. So I definitely know the differences in like between the two. So an optometrist is mostly there to prescribe glasses and contact lenses, can do some basic eye health screening and treatment. an optometrist is not a physician, so it's so they do like more basic stuff. And when it becomes more complex, then they refer to ophthalmology. So the difference between an optometrist and a neuro-optometrist is the neuro-optometrist did 1 more year of training and deals with a lot of double vision problems. And if the vision is kind of unstable or concussion patients, so they tend to manage that by doing some vision therapy. In ophthalmology, so you have the regular ophthalmologist, which is like 4 years of medical school and then 4 or 5 years of ophthalmology, depending on where you train. I'm Canadian, so that was 5 years in my case, plus 1 year of a neuro-ophthalmology fellowship. So the regular ophthalmologist is very good at treating the dry eyes and all the different other health issues like related to the eyes, is not as familiar with the eye movement problems or the double vision. So the neuro-ophthalmologist has more training in neuro, so we do see a lot of patients with brain problems and double vision as well. So I think of all like the different ones, I think depending on the symptoms that you have or the stage where you are in the disease, it's fine if the patient starts with an optometrist just to deal with their regular glasses problem and dry eye problems. But when it becomes more complicated, that's when I will say that it's probably better to transition to ophthalmology. And if it's double vision, it's pretty certain that the ophthalmologist will refer to neuro-ophthalmology. We're kind of like the last step in the line of like providers that the patient can see. So, and I want to say, there was something else I want to say. Oh yeah, if there's blepharospasm, some regular ophthalmologists do feel comfortable with doing that, but I'll say it's probably a minority. So I will say MSA, PSP, CBD, if there are some vision problems or concerns, I think a neuro-ophthalmologist is probably the best person that can manage all the different symptoms that the patient has. Yeah. But if it's early on and it's only like glasses, that's fine if it's an optometrist.
Yeah. And also just to add to that too, that a lot of patients will have an ophthalmologist and a neuro-ophthalmologist or an because if they have cataracts or glaucoma or macular degeneration or something, that can be managed by ophthalmologists, and then you could work closely with them as you're managing more neuro-related stuff.
Yeah, that's a very good point, because of course when you have PSP, you can still have other eye problems, and in neuro-ophthalmology, some people will do cataract surgeries, but I'll say it's probably a minority of neuro-ophthalmologists. So it's probably better to have a regular eye provider to deal with the regular stuff. And then everything that is PSP related can be managed by a neuro-ophthalmologist. And it definitely adds to the pile of different symptoms that the patient can have if the cataracts start developing, and then macular degeneration becomes an issue as well. So on top of having double vision and dry eyes and like not being able to open the lids, maybe the vision is not perfectly normal because of macular degeneration. A low vision specialist sometimes can also be helpful, because then we can provide like devices to try to help with the decreased vision.
So you're thinking like a low vision occupational therapist.
Yeah. So very often the patients will have like a pretty big team. So the neuro-ophthalmologist can provide some, I'll say, standard like glasses to help with vision. But when it comes to having devices to magnify, so that's really the low vision specialist that has all the equipments to show the patients.
Yeah. And I know this is available in our area here in North Carolina. It might not be available everywhere, but it does exist elsewhere, but there are low vision occupational therapists who can even come into the home sometimes and do, assessment from that lens, no pun intended, of, low vision adaptations that are needed, and even seemingly small things like putting tape over certain buttons on your microwave, I've seen, to, larger home modifications just to help you live more independently.
Absolutely.
With your low vision.
I do, here at Duke, we're very fortunate. I mean, we have all the different subspecialties, including low vision. So I do share quite a fair amount of patients with the low vision department. They are very helpful, and they have a lot of different tricks and devices that can be helpful to the patient. The good thing is, like with PSP or MSA CBD, if there is no other eye health issues, usually the vision is not too affected. It's mostly like double vision. So I don't necessarily have to send all my patients to the low vision department, but they are always there if needed.
Yeah, it's a great resource to have. I'd love for us to talk a little bit more about double vision, because I'm getting a lot of questions about that. And
yes.
People are asking, are there alternatives to prism glasses? And I know in the past I've learned from you, and I've had patients with this, where we look at are they appropriate for prism glasses versus those prism stickers that go on glasses? I remember you talking about how that's a less expensive version if it's thought that they're going to, need it progressively. I mean, glasses are not cheap. So I'd love for you to talk more about that.
So I didn't go into all the details because I didn't have that much time for my talk. But yes, so the prisms, we can prescribe two different types. So the first one is the temporary one, which is just a stick-on that we put inside the glasses. And that's the one on the slide that we could see with the lines. The advantage of that is that we can try first and see if it's working. And if the patient feels that the amount is not enough, because we have different amount of prisms, so we can very easily increase it without having to change your glasses. So that's usually my first step, right? So if the patient is comfortable with that, then I can order glasses with the prism inside the lens. So it's ground in, so you don't see the lines, right? It's invisible. But before I go to that step, I want to make sure that prisms are actually an option. So first step, the stick-on until we find the right amount, and then we go to glasses. Since it's something that tends to be progressive over time, we have to be aware that if we go with glasses, there's a very high chance that in the future, we might have to change the glasses to increase the prism. It could be once a year, twice a year, maybe less than that, but it's definitely something that tends to progress. So that's why I like the stick-on. The problem with the stick-on, because the lines are there, it gets dirty. And the lines also decrease the vision a little, and you get a lot of glare because they're like prisms. So every time the light hits a prism, it goes in different directions. So you see a lot of rainbows. When it's a small amount, usually it's very well tolerated, but the higher the amount, the more blurry vision you get from that, and the more rainbows you get as well. So another thing is, like, in terms of the amount of prism that we can prescribe, the stick-on, we can go quite high because it's a very thin layer. If we want to put it in the glasses, we are limited. So when they want to cut the lens, it cannot be super thick on one side and thin on the other side, because the lens will break when they will try to cut it. So we're usually limited to about 8 to 10 per eye, which means it's about like 16 to 20, like the total that we can put in glasses. With the stick-on, we can go all the way to like 40 if we want. The vision is very blurry because it's a high amount, but we can still do it.
Okay.
So double vision, well, sorry, go ahead. So because I didn't talk about surgery, because surgery is definitely an option for double vision. It's harder with the convergence problem, because the double vision is only up close, right? Up close, the eyes are not going inward, so the eyes are kind of going out. But when the patient looks at distance, usually the eyes are pretty much aligned. So if I fix something up close, I might mess up with distance. So surgery is not ideal for this specific problem. If it's a problem of misalignment, like up and down, or if there's also misalignment at distance, sometimes we can move muscles around to try to help with the double vision. It really depends on the alignment, and every patient is different. So surgery is sometimes an option, but not always.
Kind of depends on what's going on. Exactly.
Yeah, absolutely.
Okay. I was going to ask about surgery because a few people asked about that, and in relation to the double vision. So thank you for addressing that, but also in relation to eyelid apraxia and blepharospasm, is surgery ever appropriate there? And if so, when?
Right. So you can cut like the muscle that takes care of closing the eye or opening the eye. You can make it shorter to bring the lid up. It's an option. Is it the first line? Absolutely not. Right. So usually we try Botox, and you can even try just taping the lid up. Some people will do surgery for that. It's possible. It can work, but it does not necessarily work. It can work for apraxia because it's a very soft closure. So if you bring the lid up, the eyes might still a little open. But when it's like the forceful closure, even if you cut the muscles, sometimes the eyes will still close. The downside of doing surgery is like if you cut the muscle and you keep the eye open, it might be harder to close the eye, and it might worsen the dry eyes because you're losing your wiper effect. So if you do surgery, you have to you don't want to be too aggressive, right? Because you can help with one problem, but you can make the other one worse.
Yeah. So it's like a cost-benefit analysis with.
Exactly. So that's why surgery usually is not the first step. Botox is definitely better. And with Botox, you can also worsen the dry eyes and the double vision. But if it happens, it's usually something temporary because it only works for 3 months.
Okay, we have 6 minutes left, and I have a whole bunch more questions. I'm going to try to get to as many as I can because it's such good information. I would be remiss if I did not bring us back to dry eyes because of the number of people who are asking about them. And I want to preface this with whatever you share. For everyone out there, we want you to know that this is not meant to be medical advice, and we encourage you to talk to your provider if you have concerns or to address personal questions. But Dr. Boisvert, a lot of people are asking, are there eye drops or artificial tears that are better than other types? I know there's a lot out there. Some people have tried some artificial tears that haven't worked or have burned more. So, what's sort of your recommendations around that?
Yeah, that's a very good question. So every patient likes different eye drops. So personally, for myself, I like the ones that are a little thicker because they work longer. So I go preservative free, and I tend to go with a gel. The downside of that is because it's thicker, when you put it inside the eye, it blurs the vision. So you really have to blink multiple times before the layer gets thinner, and then you can start seeing through that big layer of tears that you just added to your eyes. The advantage is because it is thicker, it works for a much longer period of time. So instead of having to put drops in your eyes every 15, 20 minutes, you might be able to do it every hour or 2 hours. So I like the gel, the preservative-free gel. Some people don't like it and prefer to go with just the regular, very thin eye drops, which is totally fine. I will very highly recommend the preservative-free ones, though, just because if you tend to use it often, you'll get a lot of irritation if you use the ones with preservatives. Be careful. Don't go with the ones to get the red out. I don't want to give any brand names, but these drops are really just to be used once in a while. If you go to a wedding and your eyes are red and you want to have very bright eyes, you can put one drop in both eyes, and that's fine. But it's definitely not something that you can use 8 or 10 times a day. So preservative-free, either a regular tear or something a little thicker. I will not recommend going with something very thick like a Vaseline, almost like a ointment during the day, because you won't be able to see for 30 minutes, an hour after you put the ointment in your eyes. But this is very good at bedtime, especially if you wake up with very irritated eyes. It might be that the eyes are drying out at night. So those very thick ones are very good for that.
Okay, great. I'm trying to think of what we should sort of focus on our last few minutes here. Sort of two big ones jump out to me. One is a few people have asked for you to say more about patching, like when that's appropriate. Is it one eye versus another, and how long people typically have to wear a patch for during the day, or generally?
So with kids, we have to be careful with patching. We have to limit the amount of time that the patch is on because the kid can lose vision from that. Luckily, in adults, it's not an issue. So we can wear the patch as much as needed. It doesn't matter which eye we patch as long as one eye is closed, right? So if you, for example, my left eye is very dominant. When I cover this one, I don't feel comfortable. I prefer patching my right eye. So for me, I will go ahead and just patch my right eye all the time. Some patients don't really mind which eye is patched, and then you can just alternate between the two eyes. There's no limits, right? You can patch all day if you want. Since the double vision tends to be mostly up close, if you're like watching television or like just looking far away, you don't necessarily have to have the patch on. But if you're reading, then you might want to put it on. Personally, what I usually recommend is just to put a piece of Scotch tape over one lens. It's way more comfortable than having to actually have a patch with like a band around the head, or even like a sticky patch that can give you skin irritation. So a Scotch tape is very cheap. We all have Scotch tape at home, and it's something that can be put on the glasses and just like removed if not needed. And it's much more comfortable.
Okay. Helpful, thank you. Another question that has come up a lot, and this might be our last question, although I know there's a lot of other ones we really get to, but can you talk a little bit more about light sensitivity? I know I heard you mention that it can be caused by dry eyes, but a number of people have shared that the person with PSP or CBD or MSA wants to keep the house really dark, that they're squinting a lot, which can impact how they're walking. They're not wanting to go outside. Some people have asked what kind of glasses are appropriate for light sensitivity, and who's the best person to assess for that.
Yeah, that's a very good question. I think the first step is really to fix the dryness and be very, very aggressive with the treatment. So eye drops is just the first step, right? The plugs are good, but we do have other options for dry eyes. So you want to address that first. If the dry eye is addressed and it's still an issue, you can try the FL41 lenses. So it's F as in Frank, L as in Leah, 41, so 41. It's kind of like a pinkish tint. And of all the different colors that have been tested, it's the one that has been shown to work the best for light sensitivity. So that is something that I recommend very, very often in my practice. And if we have a second, I actually have it like right here. I can get it for you. I'll be right back. Okay, sorry.
It's show and tell. I love it.
It wasn't my white coat, so let me just put my... Okay. So they look like... I don't know. Let's see. Okay, sorry, it's kind of like hard. They look like this right here.
Okay.
So it's a little pinkish. And usually when I show that to my patients in clinic, I just put that over their eyes, and they immediately feel that it's like,
they might not necessarily need those like really big, really dark ones.
I mean, the dark ones are good for outside when it's sunny, but I will not recommend wearing that inside the house, because the problem is if you always wear sunglasses, your retina becomes adapted for darkness. And then when you don't wear the glasses, the light sensitivity will be much worse. Yeah, sunglasses, it's only for outside. Inside the house, go with these ones. And these ones can be found online. I won't give any websites, but if you Google FL41 lenses, you'll see there's quite a few places where you can buy them from. And you can buy like big sunglasses with like edges. You can buy a clip-on. They have like a lot of different options. But yeah, that's what I will recommend.
Those are literally rose-colored glasses.
I know they are. They're super cool.
They're very fashionable. Well, okay, so I do want to be mindful of our time. I know that we didn't get to everyone's questions, but I do think you covered a lot. So hopefully you kind of just naturally answered a lot of people's questions. But, you know, everyone out there, if we didn't get to your questions, again, please write to us. The main email is info@curepsp.org. And we're in contact with Dr. Boisvert. Maybe we could ask her some separately, or we could get you again to the right resources. If there's more that you need to learn today. And again, make sure to talk to your provider, talk to your neuro-ophthalmologist about what's going on specifically for you, because this is really just like an overview of that can relate to everybody, but everyone has such individualized needs. If you all can hang out for a few more minutes, I do have a couple of good announcements that I'd love to share with you. But Dr. Boisvert, thank you for taking the time to be with us today, to share your expertise, to answer our questions from our community. And thank you to everyone watching and interacting and submitting questions. Again, always lovely to work with you, Dr. Boisvert.
Thank you so much for inviting me. I mean, it's always a pleasure to have the opportunity to talk to patients with PSP, MSA, and CBD. And to work with you, it's always a pleasure, of course.
And then for everyone who is still with us right now, a couple of announcements before I let you go for the day. I'm excited to share that Cure PSP's virtual spring family conference will be on Monday, April 25th. We're going to have a really great lineup of speakers, actually from all three of our Cure PSP centers of care in California. And they're going to be covering everything from research updates in PSP, CBD, and MSA to physical therapy tips to sleep changes and treatment options, firsthand lessons learned throughout the journey from a panel of patients and care partners. We're also going to have an interactive discussion session after the conference for the attendees. So I hope that you all can join us. Again, April 25th, you can learn more and register. Registration is live by visiting the main Cure PSP page. So that's psp.org. And then you scroll down to the part where it says events on the bottom. Also, our next Ask the Expert webinar, like this one today, will be on June 27th. More details to come on that, but right now we are planning to have a speech-language pathologist from one of our centers of care to discuss swallowing changes and treatments with PSP, CBD, and MSA. So please save the date for that. I know that swallowing questions and changes are really common in these three diagnoses. Again, like all of our webinars, today's webinar will be archived on our Cure PSP TV YouTube channel and on our website in the next few days. We also encourage you to check out our YouTube channel to view previous webinars as well as other educational content that we've recorded over the years. And lastly, Cure PSP is able to offer these webinars and all of our events and supportive programs because of generous donations from our community. So thank you all for your support. Dr. Boisvert, thank you again. Please take care, and everyone have a great rest of your day.